Now, in the last session, we had discussed about the seizures and particularly convulsive seizures, major epilepsy as emergency. Now, the petit mal epilepsy or absent seizures is not really an emergency, but can be risk for self or others. So, it's not really an emergency in terms of what we consider as a medical emergency. No, and they just for the sake of discussion, and as we are in the context of discussing about the seizures, I'm just referring to that part also. Absent seizures, the earlier nomenclature was petit mal epilepsy. Now they are named as absent seizures, and they are classified into typical absence, where the person would be somewhat not totally unconscious, but without that tonic and clonic phase. That's the typical absence. Atypical absence, the patient is not really totally unconscious, somewhat absent-minded, something of that sort. Myoclonic absence is where there would be some under these uncontrolled movements of certain area of the body. At the same time, the patient also would have some altered consciousness. That's the myoclonic. Eyelid myoclonia is where it's only the eyelids which tend to move. So that's all the issue. The typical presentation would be there would be behavioral changes, staring spells. Staring spells is the patient would be just blank looking at certain object and he is not able to respond to the stimuli around, or rarely it may present with the seizures. Of course, they are further classified as complex partial or absence. Now, these are not really very important from the clinical point of view, but maybe just this typical would be in the case of complex partial, there could be a partial onset. There is a gradual and then progressive. At times it could be very mild and at times it could be more severe. And usually it lasts for a longer duration of more than 30 seconds. Whereas a typical absence would be always less than 30 seconds. And in case of a complex partial, there would be the repeated movements. The same movements may be repeated, and then there could be certain physiological activity like either salivation or maybe the say urination, defecation, etc. Automatisms tend to occur, which in case of absence condition, generally it's not present there. But if it is for a longer duration, it will not. It may be there. In both the conditions, patient would not be aware of the situations around. And when it ends in a complex partial, it's gradual ending, whereas in case of absence conditions, it's a abrupt. That's how it's classified. Of course, none of them are emergencies in general, but there can be an emergency if it is in a very typical situation, like a patient is driving, or maybe patient is on a height where he cannot support himself, or so on. So all that important is such patients should be avoided with such a high risk jobs or high risk environments, like exposure to fire, exposure or these carrying heavy weight on busy areas or height, climbing height, so on. So such food activities should be avoided. Of course, from the treatment point of view, the drug of choice is ethosuximide. Occasionally, antiepileptic drugs also are used. That's about the seizures and convulsive disorders. The next part which we discuss would be the respiratory emergencies. Now, in the respiratory emergencies, one part we have already discussed, oxygenation and the techniques of oxygen supply. We have already discussed in the beginning, in the first session itself, we have discussed, because that oxygen supply is a life-saving measure. Now, in the other conditions, where the patient would have a respiratory insufficiency, and we call certain of conditions as respiratory emergencies. Among them, the one is the status asthmaticus. Status asthmaticus is a persistent episode of the breathlessness where the oxygen exchange would be reduced, or it could be pulmonary embolism. Acute respiratory distress syndrome is again a very specific syndrome where all of a sudden the patient would have a respiratory distress and pulmonary edema due to cardiac pathologies, tension pneumothorax, respiratory failure due to central toxicity, or maybe due to drugs, or maybe poisonous substances, or even it could be due to a damage to the respiratory center due to trauma, or decompression syndromes where the patient may have compression of the chest, and or it may be as in case of this a person who is diving deep in and then coming up. Now, once what happens is when you dive deep, there could be the gas would be dissolved. That's also called as Kaysen's disease. Gas would be dissolved at a high pressure, and particularly nitrogen would be dissolved in high pressure. But when the person is exposed to the this atmospheric pressure, and suddenly there could be bubbles of gas form. Or a similar situation also can occur if the pressure, this maintenance of the pressure in the aeroplane is affected. See, in the aeroplane, the pressure is artificially maintained at a higher level when it is reaching to the height. Suppose somebody opens the tip window or something happens, and then the pressure in the aeroplane reduces when it's in the height. The similar situation can occur. There could be bubble formation of as because at the lower partial pressure, the dissolution component of any gas in the liquid would be lesser, and hence it tends to form the bubble, and this results in the respiratory obstruction. So that's the decompression syndrome, or aspiration pneumonia, or airway obstruction due to mechanical obstruction, something like obstruction as such. Now, in all that, we classify the respiratory failure into two types. One, the type one is a respiratory failure which involves low oxygen and normal or low carbon dioxide levels, where oxygen is lesser, but the carbon dioxide level is not increased. Whereas in case of type 2, which is a ventilatory failure, where the patient is not able to have the exchange of gas in the lungs, and in such conditions, the problem would be both oxygen as well as carbon dioxide would be, carbon dioxide would be high and oxygen would be lesser. Now, the basic issue would be in case of type 1 respiratory failure, if we provide oxygen and make the patient get oxygen, that would be enough. But whereas in case of the type 2 respiratory failure, you need to ensure that the carbon dioxide also is evacuated. Or rather, the other way, in a type 2 respiratory failure, you need to have a mechanical ventilation. The ventilation has to be maintained. Whereas in type 1 respiratory failure, it could be just you provide the oxygen and ensure that the oxygen is reaching to the circulation. The patient will revive. So that's all the condition. And clinically, this is to be differentiated, and differentiation is not very difficult, but occasionally you may have a confusion like whether that patient requires the ventilatory support or not. And in such conditions, spirometry can be one of the important tools to make out that. Or if you have that facility of blood gas analysis, carbon dioxide concentration, it also can help. Pulse oximetry, to a certain extent, it can help. Pulse oximetry, oxygen concentration is available, but you cannot get the carbon dioxide concentration. So, if a patient has a normal rate of breathing and the oxygen level is below normal, in that condition, it may categorize as type 1. If the volume of the breathing is lesser and the oxygen concentration also is lesser, then you have to think of type 2. So, from the clinical point of view, when you do not have the facility of investigations, the best is auscultation. On auscultation, if the inspiratory sound is shorter and the inspiration is intensity of the inspiratory sound is lesser, you consider this as a possibility of type 2 this respiratory failure. If the inspiratory sound duration of the inspiratory sound is normal, but expiratory sound is longer, the phase of expiration is much longer than the normal, in that condition you consider as type 1. Majority of the patients whom we treat in our hospitals is usually type 1, and the conditions like tuberculosis, pneumonia, and or fibrous lung tissues, they usually end up in type 1. But the patients with the muscular pathologies, neuromuscular pathologies, like these very commonly seen in Guillain-Barré syndrome patients. Guillain-Barré syndrome patients with the acute phase or amyotrophic lateral sclerosis, ALS-like conditions. When there is a muscular pathology, or even case of a motor neuron disease, it can occur. The muscles would be affecting, and hence the inspiratory phase would be lesser, and that's an emergency where a ventilation is required. Such patients cannot be treated in our hospital where we do not have a ventilator. or in very occasional obstructive pulmonary disorders also you may have that kind of a situation. Patients with chest wall deformities, trauma, it also can result in the similar situation. Now, another important issue in a patient with the type 1 respiratory failure, again, you will have, it also can be classified into two obstructive disorders or restrictive disorders. In any of the patients, this also is important. Obstructive disorders are when the airway is obstructed, the resistance given to the airway is reduced. Restrictive disorders are where the total lung volume itself is reduced. This also is important because in an obstructive disorder, you need to ensure that the flow of air is facilitated into the lungs. In the type 1 respiratory failure, you have this classification obstructive and restrictive. And in the obstructive conditions, along with the providing of the oxygen, you have to ensure that the air moves into the lungs in a better way. The resistance of the airway has to be reduced, or rather simple, a bronchodilators like drugs may have to be given. In restrictive disorders, where the total lung volume is reduced, the effort of breathing has to be enhanced. And effort of breathing can be enhanced either by artificial respiration, where you may have to use that ventilator, or you may need to stimulate the respiratory center. The respiratory center need to be stimulated so that the respiratory center would itself would be activated. Now, whether a stimulation of the respiratory center would be enough or you need a ventilation, this is a question mark. A safer would be always a ventilation, external ventilation, where mechanical support given to the lungs and ensure that the lung expands. Like you may have to use a positive pressure ventilation. Now, when we discussed about the administration of oxygen, we have discussed that like when you use a ambu bag, where you can push the air in, that's in case of restrictive disorders. Whereas in obstructive disorders, simple mask or maybe the oxygen tubes could be enough. So that's all the point. Or in a patient who is on already ventilatory support, you need to assess this whether there is a obstruction still persisting or whether it's only the restrictive conditions to decide like whether the ventilation can be switched off or not. So anyway, that's all the important issue. And in every patient whom you see, you need to assess this. Now, majority of the patients whom we see in the clinical practice in our hospital setup, among the patients who come across, we more have obstructive disorders than restrictive. Restrictive disorders are common in case of the interstitial lung diseases or patients who have a neuromuscular cause, patients who are markedly obese, there could be restrictive disorders where you need a ventilated support. Or rather, practically the other way, when you are administering oxygen and if the oxygen has not given results, it could be restrictive disorders as such. Now, simply to explain the same obstructive and restrictive, the issue I have shown you the diagrammatically. In an obstructive disorder, the lung would be dilated, the inspiratory sound would be long, and rhonchi would be always characteristic. In obstructive disorder, the rhonchi is characteristic. Expiratory sound is very prolonged and maybe have low intensity. There will be more of locked air sign. When you percuss, there could be hyperresonance. In case of restrictive disorders, the intensity of the breath sounds would be diminished. There will be a shorter inspiratory sound and longer expiratory sound. That's how you can make out. And the total lung capacity is reduced, and hence the total volume of breathing also will be reduced as such in case of restrictive disorders. Now, the other way, so one of the assessment would be in a patient with respiratory emergencies where the patient doesn't have enough of oxygenation, where breathlessness is the presentation. One of the things which you have to decide is whether it's a type 1 or type 2, and then if it's type 1, you have to confirm whether it's obstructive or restrictive. In addition to that, certain of the other basic assessments which you have to do in any patient with a respiratory emergency will be whether the patient is able to talk or cry. Now, if patient is able to talk or cry, it's very confirmed that the airway is patent. There is no question of airway getting blocked or airway obstruction is not there. And when I say obstructive or obstruction is not there, it doesn't mean that the spasm is absent. Spasm may be still persisting, but Mechanical obstruction, like a aspirated substance or maybe certain foreign body getting into the lungs, is not present if the patient is able to talk or cry. Snoring or gurgling sounds may be suggestive of a partial obstruction. If the patient has a gurgling sound, bubble-like sound, that suggests of a partial obstruction. Now, if the patient has shown that expiratory muscles, accessory expiratory muscles are in action, as accessory respiratory muscles are the muscles of the neck, muscles of the abdomen also are seen during the breathing, that suggests that the patient has a acute respiratory distress, and that's again a possibility of a restrictive lung disease, and you need to support the respiration. Reduced respiratory movements. If the total respiratory movements are reduced, that suggests of a ventilatory abnormality. The same thing which I have already referred to. Then asymmetrical movements of respiration. If the respiration is not symmetrical, if the lung expansion on one side is more compared to the lesser, then you'll have to consider the tamponade effects where the pressure within the pleura has been increased, which is also a restrictive pathology. Tension pneumothorax or pleural effusion as such, that's also a restrictive pathology. A labored and rapid breathing, if the patient is having more efforts of breathing and the rate of breathing is rapid, you need to suspect acute respiratory distress syndrome. These are certain basic assessments which you have to consider. Now, the general principles of the management in case of a respiratory emergency, the first of the thing is you have to be sure that the airways are patent. Then whether the ventilatory support is required or not, that has to be decided. I have given you the idea like when the ventilatory support is needed or not. If it is needed, it has to be provided as early as possible. Then provision of the oxygen, and glucocorticoids often are considered to be one drug, non-specific drugs, which will help in patients to meet the stress. See, after all, respiratory abnormalities would be acute stress, and the quite important is ensure that the patient survives that stress condition, and hence glucocorticoids are usually given. Then the specific drug would be bronchodilators. When you administer bronchodilators, you have to be sure that it's only an obstructive pathology or obstructive type 1 disorder. If it's a restrictive pathology or if it's a type 2 condition, bronchodilators are not going to help, and particularly in type 2 respiratory failures, bronchodilators even can harm if you have not provided the ventilation. See, after the ventilation, bronchodilators can be given, but in case of a type 2 abnormality, without ventilatory support, if the bronchodilators are given, it can harm the patient, and hence, before you administer any bronchodilators like aminophylline, deriphyllin, and so on, you have to be careful, which is very commonly prescribed. Then diuretics, of course, would be only in case of pulmonary hypertension. Patients with the chronic lung pathologies also would have a risk of pulmonary edema, even if the cardiac functions otherwise normal. And hence, a small dose of diuretics are often administered in such cases. And if it is a primarily pulmonary edema or pulmonary hypertension, as in case of cardiac pathology, diuretics are the drugs of choice. If the patient also has a ischemic heart disease, nitrates could be given. Nitrates are administered as such. Then most of the patients in respiratory failure would result in acidosis, respiratory acidosis. Now, acidosis as such, we will be discussing separately after this, and during that period, we will have more discussion about the acidosis. And one of the types of acidosis is respiratory acidosis. Any patient who has a respiratory failure would have acidosis, and it needs to be corrected with the alkaline substances. The usual drug is a soda bicarbonate, sodium bicarbonate is given. Then centrally acting respiratory stimulants. At one stage earlier, when we were studying, like the centrally acting respiratory stimulant drugs were quite more frequently used, and they were the drugs of choice. But now, because you have more of facilities of artificial ventilation, the artificial ventilation or ventilatory supports are considered as the first choice. Respiratory stimulants are limited to only those conditions where even the ventilatory support has failed or ventilatory support cannot be given. So, primarily, the choice now has been shifted to a mechanical ventilation than the centrally acting respiratory stimulant now, but still it has a scope in those conditions where you do not have a facility of ventilatory support. Centrally acting respiratory stimulants can be quite useful. Now, very brief about the bronchodilators and central acting respiratory stimulants. I will not go into very detailed pharmacology. Now, bronchodilators are mainly of three categories. One, sympathomimetics, drugs which have sympathetic-like action, or xanthine derivatives, which are smooth muscle relaxants of the these respiratory smooth muscles, they are relaxed directly, and anticholinergics are atropine, which will prevent the constriction to a certain extent. Now, in case of type 1 type of respiratory failure and restrictive type failure, it's the sympathomimetics which are always better preferred. Among the sympathomimetics, ephedrine is the drug of choice in general because ephedrine would be both cardiac stimulant as well as a respiratory stimulant. It stimulates the respiration and hence it is considered to be more specific drug of choice among the non-selective. Then beta stimulant, among the beta stimulants, salbutamol is often used or tarbutaline. Now these days salbutamol has become quite popular, and particularly salbutamol with the salbutamol, it's one of the problem would be it because it increases the circulatory pressure. If the patient is hypertensive, better not to give salbutamol. Otherwise, it's used. Then transient derivatives like deriphyllin, which is with aminophylline, such drugs, they are given preferred in case of obstructive type 2 failures, obstructive pathologies. Only it's indicated. If you administer it in the type 1 failure, it can result in more complications as such. So, terifilin should be limited to obstructive and particularly where there is a spasm. See, it relaxes the muscles, and if there is a spasm, if you have bronchi, then it can be administered. Beta stimulants are preferred only if the BP is reduced, whereas with the smooth muscle relaxants like xanthine derivatives, aminophylline, there is a risk of hypotension. If the patient's BP is at a lower level, better not to administer aminophylline or deriphyllin. That's it, in brief as such. Atropine is reserved only for those conditions where there is a organic compound poisoning, like where due to the organic compound poisoning, the respiratory obstruction has occurred. Yeah, organic compound poisonings are insecticides and so on. If such a patient is there, then atropine is the drug of choice. In other conditions, atropine is generally reserved only for those conditions where there is a cardiac involvement and it acts as a both cardiac stimulant and slightly, marginally relaxes the respiratory muscles. So atropine is reserved only for the such toxic pathology induced compound. Of course, in a respiratory emergency produced due to organic compound poisoning, atropine is the drug of choice, and the upper limit of the atropine dose in such condition is till the patient's pupils become dilated. So it has to be the maximum dose. There is no such a limit as such. In other conditions, atropine is not the first choice of the drug. That's in brief about dealing with the respiratory emergencies. Then the centrally acting respiratory stimulants, that's among them, the most commonly used drug is nicotinamide. Nicotinamide is one of the drug which is quite commonly used as such. Of course, as I told earlier, in the present day situation, it has become less popular. Then the carbon dioxide itself, with the mixed with the oxygen at 5 to 7%, can act as a respiratory stimulant. Now, carbon dioxide is administered either in case of ventilators or rarely in the Bell's apparatus along with during anesthesia. During anesthesia, when the respiratory muscles are already paralyzed due to anesthetic drug, and if the patient has developed carbon dioxide, this type 1 failure, carbon dioxide is used to, because carbon dioxide can stimulate the respiratory center. Now, what happens is during anesthesia, if there is a overventilation, if the anesthetist pumps more frequently, that compression is done more frequently, then there could be a depletion of carbon dioxide, and that carbon dioxide depletion may result in a respiratory center failure. Respiratory center doesn't get a stimulation, and hence the patient may not recover. So, in such conditions where the patient doesn't recover, even after cutting off the anesthetic drug, carbon dioxide can be administered. So it's having a very limited role. Or in such a situation where the patient is not responding to the ventilatory support, or even after ventilatory support, if the patient is not able to regain the control over the respiration, carbon dioxide could be used. Then sulfocampagine also is often used, but not as popular as nicotinamide. Then earlier days, in the olden days when we were studying, ammonia solution was quite frequently used, but now ammonia solution is not used. But I am referring to that as a because it has a historical importance. Historically, at one stage, ammonia ampoules were quite frequently used as respiratory stimulants. A person who has a respiratory failure will break open an ammonia ampoule and make the person smell that. But during that, the doctor also will be smelling ammonia, and that ammonia smelling is quite irritated. So now, of course, ammonia solution is not available in the market. So from the present day's point of view, this is obsolete. Then Lobeline is also still used, particularly in the patients who have smoking cessation and then respiratory failure. See, persons who have a continuous smoking, and if they are stopped, the smoking is stopped suddenly, they may develop a respiratory distress like symptoms, acute respiratory distress like symptoms can occur. In such conditions, low hydrochloride is the drug of choice. Usually at low dose like 2 milligram is often given, which can make the patient recover easily. Then centrally acting drugs like caffeine, simple coffee also can be a respiratory stimulant, but from the clinical point of view, this is not frequently used as in the ward. But if a patient has a otherwise mild respiratory distress, a cup of coffee can help in patient recover to a certain extent as such. Or caffeine directly also can be administered intramuscularly, though rarely. And then the Bemegride is still used particularly very specifically in barbiturate poisoning. Bemegride is a specific antidote in barbiturate poisoning like condition. Another common respiratory abnormalities or respiratory failure conditions which we meet in casualty would be barbiturate poisonings, like those who tend to attempt for suicide, or at times it could be homicidal, where excess of that barbiturate drugs are consumed, and in such conditions, Bemegride is the drug of choice, and along with the ventilation. That's about the respiratory stimulants as such. Now, in case of a tension pneumothorax, now one of the other emergency in the clinical practice would be tension pneumothorax. Now, pneumothorax means where the air leaks into the pleura, and air can leak into the pleura due to either a opening on the chest wall, and air may move into the chest wall, or air may move from the lungs into the pleura. In the pleura, normally the pressure is lesser than that of the atmospheric pressure or negative pressure, and that negative pressure is essential to keep the lungs expanded. Because the pressure is less than that of the atmospheric pressure, the lungs will keep adherent to the parietal pleura, and as the chest wall expands, the lungs also will expand. If somehow the air moves into the space, either from the exterior or interior, then the lungs tend to get constricted, because lung is elastic tissue and it tends to get constricted, and air tends to accumulate in the pleural area. Now, there could be three possible situations. Suppose, and most commonly what we see is the spontaneous pneumothorax conditions. Spontaneous pneumothorax conditions in the sense, due to some pre-existing disease, the lungs tend to get ruptured and air flows into the thoracic pleural space. Rarely you may get a head penetrating injury where the air gets into the pleura. In both the conditions, there could be a possibility that the opening through which the air has flown in may get spontaneously closed. That's what we call as a closed pneumothorax. In the closed pneumothorax, if there is no more air flowing in, now particularly with the spontaneous pneumothorax, it may end up in a closed pneumothorax quite easily, because suppose there is a opening in an expanded condition, and as the lungs tend to get constricted, that opening may get closed. If the opening gets closed completely, there will be no more air moving into the pleura, and it's not an emergency. That doesn't become an emergency, because further there will be no further compression of the lungs, and all that you have to do is ensure that the patient gets sufficient ventilation, and either you may suck the air out, or you may just wait for the spontaneous resolution, taking care of the condition of the patient. But The other way, there could be another possibility, a open pneumothorax. Open pneumothorax where the opening remains as such, and particularly if there is an opening over the thoracic cage, if there is a penetrating injury over the thoracic cage, the air may flow in as well as air may flow out. During expiratory effort, the air may flow out and air may flow in. And in that condition, the pressure in the environment, this pleura would be equal to that of the atmospheric pressure, and hence the lungs may get constricted. That lung may get constricted, but it may not produce compression upon the mediastinum. Mediastinum will not be displaced. This also is not an acute emergency, but still it has to be considered as emergency because one lung tends to become totally dysfunctional. The patient has to live on only the other lung, but one lung would be enough to maintain the ventilation because lung reserve is around 16 times, and hence the patient may survive, and you have sufficient time to plan the management. The third one is the tension pneumothorax. Now, tension pneumothorax is the one where the opening is formed in the lungs due to the rupture, and as the lungs collapse, that opening may act as a one-way valve, where air may get sucked in during the inspiration, and during expiration, as there is a tendency for the valve to get closed, you have a flap of the lung tissue covering the opening, the air may not go back. And this is a very critical situation where the pressure in the pleura can go on increasing beyond that of the atmospheric pressure. Now that results in acute distress, and it also can result in compression of the mediastinum, and cardiac distress can occur, and it's a acutely fatal condition. If you have, and the maximum time duration during which the patient may survive would be around 15 minutes. You need to ensure that the tension pneumothorax is reverted or at least converted into an open pneumothorax within 15 minutes. Otherwise, it can be fatal. Now, in such a condition, if you take an X-ray, you can see that the air is present in the lungs and it pushes the heart to the opposite side. Virtually because of that cardiac distress due to the displacement of the mediastinum, the patient would die. And time taken for this can be depending upon the size of the pneumothorax, size of the opening over there, and amount of the air flowing in and flowing in. So during every inspiration, if a larger volume of the air gets in and it gets blocked, it can be sudden acute emergency, or if it is relatively slow leak, then it may take better longer time, but it's a acute emergency. So tension pneumothorax is an acute emergency, whereas closed and open pneumothoraxes are not acute emergencies, but they are emergencies where you can have a planned treatment. In a tension pneumothorax, the important method of clinical identification is particularly in the wards, it can occur anytime, and it's also one of the common causes for unexplained sudden death in the ward. Patients in the ward sudden dying without much notice. There are many common causes. One is ischemic heart disease and the ventilatory circulatory failure, and another is tension pneumothorax, and then of course you have the pulmonary embolism. Pulmonary embolism also is another of the cause for sudden death in the sequence as the numbers among the frequency of the incidences. Now, the diagnosis is depending upon an accurate history where patient would have a bout of cough followed by acute respiratory distress. And when you look at the patient, you can make out the respiratory movements being diminished, and there will be hypertonic, or when you percuss, there will be hyper resonance, drum like sounds would be heard on the one side, and the displacement of the heart sounds position would be displaced to the side of where it is displaced as such. And the patient would have also the signs of circulatory failure, like cyanosis, also can occur. And the respiratory distress will be very acute and severe. In such conditions, the immediate first aid which can make the patient survive would be you insert a tube to the thoracic cage. If you do not have a facility of tube or making any incision and so on, simply insert a needle, any injection needle, just to any intercostal space. It has to be inserted on the side where there is a plural this pneumothorax. That's all important. You have to know which is the side involved and then insert the needle. Once you have inserted the needle, you can convert that into a open pneumothorax because that needle inserted will allow the gas to flow into the atmospheric environment, and the pressure within would not be increased beyond that of the atmospheric pressure. By that, you can buy a long time and the patient can survive. Later on, you can go for a planned treatment like chest tube insertion, drainage, and so on, specific treatment for the cause, and all that the protocols can be followed further. But one of the important thing is when you are in the emergency duty, in the night duty, or so on in the ward, if a patient develops an acute respiratory distress, do not miss the diagnosis of tension pneumothorax, where a simple needle inserted into the thoracic cage can save the life of the patient, and if not, it can result in a fatal complication. That's about the tension pneumothorax, one more of the respiratory emergencies. Another of the respiratory emergencies which can occur would be a foreign body getting into the respiratory tract or choking, which can again, the possibilities are many. It could be toys in children, it could be foodstuff in a person, or it could be, particularly the foodstuff risks are more if the patient is alcoholic and after consumption of the alcohol, particularly in five-star hotels. If you have gone to any five-star hotels dining room, there is it's mandatory that you have to. There is mandatorily there should be these signs of how to maneuver, treat that patient in such a situation. That emergency maneuver, that's Valsalva's maneuver, is demonstrated legally. It's the must there. Now, that all that important is you have to know whether the person has a really choking or not. So I think the history could be quite obvious. There would be very obvious history of some foreign body being swallowed, and in such a condition, if the patient is having choking, one of the important first aid, immediate first aid would be you have to take the position behind the patient, make the patient bend forwards, compress the abdomen and chest suddenly, and that brisk compression can help in expulsion of that foreign body possibly. If it is not done, if it is not possible, maybe you may be successful and save the life of the patient by Valsalva's maneuver in a good number of patients. If it is not possible, then tracheostomy is the only choice. Tracheostomy has to be done and ensure that the patient's respiratory respiration is maintained, ventilator support is given. A Valsalva's maneuver also can be done by a person himself. Now, this typical Vasalas maneuver, which I have demonstrated with this picture series, is about a assisted Vasalas maneuver. A self-controlled Vasalas maneuver also can be done. Suppose you have felt that there is some foreign body into the respiratory tract and you are feeling distress and still you are in a position to control yourself. You take this position, squatting position, compress the chest over the knee, and that positive pressure exerted itself can help in expulsion of the object. So this also is another remedy which is suggested. Of course, a similar situation mentioned in Sushruta has suggested exactly a similar procedures. Valsalva's maneuver, the same mechanics are suggested by Sushruta, where grasasyatet konthasakte nishankam anavaddham skande mustinabhyanyat. You have to beat on the back of the person without any hesitation, and that beating also would produce a compression of the chest and sudden pressure changes and help in expulsion of the object. So that's how you have to manage a person coming presenting with the choking as such. With this, we'll end up the respiratory failure conditions. The next part would be dehydration, fluid and electrolyte balances, and the patients presented with the emergencies related to the fluid and electrolytes. Before going into the, what I think, seven, uh, uh, we'll take up this in the next session because already time is 7:15. So we'll take up this in the next session. We'll wind up today. If there are any questions, I'll try to answer. Then we'll wind up today. Like there are no questions, so we'll wind up today. We'll continue the fluid and electrolytes in the next session. Right.